Okay, Dr. Mays. Good afternoon, and how are you? Welcome to Tots and Teens in Focus. I'm your host, Patricia Trim. Welcome you to another edition of Tots and Teens in Focus. And to see such a young person as an oncologist is something to wonder that our young Black people is really doing something that is gigantic and great.
Well, I appreciate you having me.
Yes. Okay. I'm trying to get on Dr. Simone Mays, medical doctor, breast surgical oncologist at Brookdale Hospital Medical Center, Department of Surgery, Breast Center. You're at Brookdale Hospital. Dr. Mays, welcome once again to Tots and Teens in Focus. I know you're not a tot or a teen, but you're just right. You're just looking like a teenager. So today we're going to talk all about about your work as an oncologist, as such a young person, and you will tell us. A lot of us may heard of breast cancer, but we never know what is breast cancer because we are told to feel our bust or feel our breast or whatever. So Dr. Mays, as an oncologist, could you tell us your creation of becoming an oncologist and why?
Okay, certainly. So growing up, I always knew I wanted to be a doctor. You know, if you ask my family, you know, Simone was saying she was going to be a doctor since she was about 7, 8, 9 years old. I always had an interest in the human body and science and how things worked and functioned. So I went to undergrad at Rutgers University in New Jersey, majored in biology, graduated, spent a couple of years actually working. I worked for a cardiologist for a number of years. Got the lay of the land, saw how a medical practice worked, and that really solidified my desire to, you know, become a physician. So fast forward, went to medical school at Drexel University in Philadelphia. And during medical school, I went in actually thinking I wanted to go into cardiology because I worked for a cardiologist. I really liked their practice. They were interventional cardiologists, so they bridged, you know, medical practice with also doing, you know, procedures. And I really liked that aspect. But when I got to my clinical rotations during my third year of medical school, I had surgery as my first rotation. And I thought I would enjoy surgery just because I liked anatomy and, you know, seeing, you know, the different parts of the body and how things kind of interconnect and all of those things. And I've always been good with working with my hands. So I knew I would probably enjoy it. I just didn't know if the lifestyle was going to really fit what I was desiring. And needless to say, I fell in love with surgery. I remember a day, I think we had been operating from like 7 a.m. to like, it was about 7, 8 in the evening. And I was like ready for the next case. And the surgeon had, you know, made a comment to me. He was like, "Are you sure you don't want to do surgery?" And I was like, I don't know, maybe I do. I'm really enjoying this. But again, it was my first rotation. So I didn't just jump all in like, okay, I'm going to do surgery now. I went through all the different clinical rotations that you go through during your third year medical school, and nothing ever really resonated with me the way surgery did. So I decided, okay, I guess surgery it is. So I did my general surgery residency at Brookdale Hospital. And during that time, again, I went into it thinking I wanted to do one thing. I thought I wanted to do trauma. And for people who don't know about Brookdale Hospital and its location, we get a lot of trauma here at the hospital. So I learned very quickly I didn't want to do trauma. Not that I didn't find the challenge of, being quick on your feet and coming up with a plan and taking care of a patient. There were just a lot of aspects of trauma that, you don't really see on, the TV screen when you're watching ER, Grey's Anatomy. It's not as, sexy as it's displayed to be on the television. So I knew I was like, I don't think I want to do trauma. So I did a year of research at Cornell Breast Center, and that really opened my eyes to the marriage between really developing a lifelong relationship with patients as a breast surgical oncologist, and also still being able to do surgery and procedures, and really seeing firsthand how you can have a major impact on the outcome of a patient right there in front of your eyes. So that was my kind of long-winded way of saying how I got into the practice of breast surgical oncology. Can you hear me?
Yes, I'm hearing you.
Oh, okay. So when I finished my residency, I did additional year of fellowship training, specifically in breast surgical oncology. And let me just kind of explain what a breast surgical oncologist is, because I know sometimes you hear breast surgeon and a lot of patients think, oh, well, do you do like reconstruction? Do you do, breast lifts? What type of surgery do you do? So as a breast surgical oncologist, my main responsibility is to manage surgically, primarily benign and malignant breast disease. So patients come in with a lump that's not necessarily cancer, but may need to be removed surgically. I handle that. Obviously, if a patient has breast cancer, I take care of the surgical aspect of their treatment. But also one of the key roles of a breast surgical oncologist is what I really was desirable for me, is that you become that kind of gatekeeper for the patient as they go through the journey of their treatments for breast cancer. Because breast cancer treatment is multifactorial. It's not just surgery. We also work very closely with radiation oncologists as well as medical oncologists. So you have a whole team of people who are tasked with getting a patient throughout their journey of treatment for their breast cancer. So really the ability to establish that relationship with the patient and follow them through their journey of treatment through breast cancer, but also as they progress beyond their diagnosis, and closely monitor them over many years. You really have the ability to establish that relationship, as well as marry that with being able to do surgical procedures and really tailor treatments to the patient and what their needs and desires are.
Okay, Doctor. Now that you have told us the reason why that you have gone on to become an oncologist, dealing with blood and all these type of things, that is very, it's something that I never thought about, because I was so scared of blood that I never thought of going into the medical field. But as a teenager and as a young child growing up, give us some of your school days, happy days, play days, before you meet to this stage of being the oncologist.
So I was very active in sports. I have a younger brother who is about 3-4 years younger than I. And we were always active. I mean, if it wasn't basketball, it was soccer. If it wasn't soccer, it was swimming. I mean, you name it, softball, baseball. I think we did pretty much all of the standard sports that kids do. And I just, regular kids always want to be outside and, going to the park. And, I mean, those were times when, my brother and I would be riding our bikes all over town. Me as a mom now of 4, I certainly, I can't imagine letting my kids just go out and ride their bikes around the neighborhood without having a heart attack, thinking about all the things that could potentially happen.
Could happen.
But yeah, I mean, that was, that was my mom was a very big proponent of keeping us busy, not only in sports, but academics. I mean, every summer we were in some sort of academic program as part of our summer activities. So yeah, that's kind of, my childhood growing up.
Sorry. Yes, I'm getting a itch in my throat. Yes, Dr. Mays, Dr. Simone Mays. To be an oncologist, what does it take? Because I know it's a lot of studies, a lot of nerve wracking. You're doing a surgery. You got to be careful if you're cutting any veins or nerve or arteries to take out whatever's inside of there. And how do you diagnose that it will be a cancer? So how do you know that it could be removed or it cannot be removed?
Right. So the diagnosis part is primarily with imaging, and more specifically, either mammogram or ultrasound, sometimes MRI, but by and large, the majority of breast cancers are detected with mammogram or ultrasound, or a combination of the two. And so you have a patient, this is kind of a usual scenario. You have a patient who, maybe having her annual mammogram, they see something new on the mammogram. They ask the patient, okay, please come back. Let's take some additional images with the mammogram and do an ultrasound of that area of the breast to see if we can better, characterize what exactly they're seeing on the mammogram. And so based on that, there is a criteria that we use to designate something as, benign, meaning it has all these features that coincide with, typical benign things that we see in the breast, versus something that we say is suspicious for malignancy. So if it's something that's characterized as being suspicious, then the next step is to recommend a biopsy.
What is benign? What is the benign?
Biopsy.
The benign.
So benign meaning BENIGN, excuse me. Benign meaning that it's not cancerous.
Okay.
A lot of times the breast tissue can kind of coalesce and come together and form little nodules that pop up on a mammogram or an ultrasound. But when you look at it, typically non-cancerous things are nice little circles or oval shape. You have a nice border or rim around it. Those sort of things. A cyst is essentially fluid that has breast tissue surrounded around it. And so we can, characterize something as a cyst based on how it looks on an ultrasound. And so those things are what we call benign, meaning they're not cancerous, they're not suspicious for cancer. And then you have other things that don't kind of fit all those criteria for things being non-cancerous. And then we characterize that as being suspicious. And that is not a diagnosis, that's just an indicator that we need to do some additional investigation in order to determine exactly what is going on. And so when you have something that's suspicious on a mammogram or an ultrasound, then we recommend doing a biopsy. And a biopsy essentially is where you stick a needle into an area of the breast tissue, take some tissue samples, and then examine it under a microscope to determine exactly what it is. And so that's typically how biopsies are done and how breast cancer is diagnosed, by examining tissue under a microscope and seeing specific changes that we see with respect to cancerous cells rather than, normal breast cells.
Does the biopsy interfere with cancer or cause it to be more dangerous? if it is cancer?
No. So there has been no evidence of, doing a biopsy causing spread of cancer to other parts of the body. That's just not, there's no evidence of that. So no, biopsies, this is how cancer is diagnosed, standard across the board. When it comes to breast cancer, is a biopsy has been done. And it typically is done either with the guidance of an ultrasound or sometimes with a mammogram, which we call a stereotactic biopsy, where they have to use a special mammogram machine in order to guide, typically it's a radiologist, sometimes a surgeon, to do the biopsy to determine exactly what an abnormality is that they're seeing on the imaging.
Dr. Dr. Mays, I took a mammogram about a week ago, last Sunday, not Sunday gone, the other Sunday before. But now I feel good because nothing hasn't come back yet, or they hasn't called me to say anything that is dangerous. So thank you for that information. I don't have to be worried about taking the mammogram, because sometimes people very scared of taking mammogram because they don't want to hear the results that will come back in. How would you encourage women on the whole to go take their mammogram?
Yes, it's very, 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 very important. I understand the anxiety around mammography. We would be hard pressed to find a person who doesn't know someone who has had breast cancer. And, unfortunately, probably many of us know people who have died of breast cancer. So it is very anxiety provoking when you go for your mammogram and you have to kind of wait and see if there's anything on the mammogram that is, worrisome. So what I tell patients is, it's better to have the information. You don't want to wait until you feel something in your breast or you start to notice discharge from your nipple, or you notice changes to the skin of the breast. We don't want to be detecting breast cancer when you're having those type of symptoms. We want breast cancer to be diagnosed, if it has to be diagnosed, when you're going for your routine mammogram and they see a little tiny nodule in your breast and they want to do some further investigation, and it may turn out to be cancer. Because we know that the gains that we've had over the last couple of decades as far as survival with breast cancer is because of early detection and also targeted treatments. But the early detection is key when we're talking about mammographic screening. And just to, put it out there, mammographic screening should start at the age of 40. I know the US Task Force several years ago released their recommendation for starting mammography at the age of 50, but breast cancer surgeons, medical oncologists, cancer societies, majority of us all agree mammographic screening should start at the age of 40. And particularly when we're talking about Black women, we know that Black women, compared to their counterparts, are diagnosed with breast cancer at younger ages. So if we don't start our screening until 50, we are really missing an opportunity to intervene on patients early rather than waiting for them to feel a lump in their breast. So I strongly encourage my patients to, understand the anxiety, but also empower yourself with the knowledge and understanding that if something does show up, more than likely it's very early and there are excellent treatments with excellent outcomes. And you'd much rather be in that position
Early detection
You'd
is
much
better
rather
than.
be, right, exactly. You'd much rather be in that position than, oh my goodness, I feel this big lump in my breast.
I will go crazy.
What do I do? Yeah.
I said I will go crazy if I feel a big lump like that. It's horrible.
Yeah. And also to that point, I do want to emphasize this. Even if you've had a normal mammogram, if, 3-4 months down the road, you notice something in your breast that you know is typically not there, do not ignore it. Go see your doctor, let them know, hey, this area of my breast, I feel something. It doesn't normally feel like this. Even if they say, oh, well, you had a mammogram 3 months ago, I'm sure it's nothing. No, get it checked out. And more than just a doctor feeling your breast, get another imaging, because I have seen it time and time again. There are types of breast cancer that are what we call more aggressive and grow quite rapidly. So certainly you can have a normal mammogram and a few months later, you can have a mass that is suspicious for cancer. So I just want to make that point as well. Even if you have a normal mammogram, if you ever feel anything in your breast that is not your normal, get it checked out and don't take, oh, it's nothing, without the proper investigation first.
I know that I have a cousin right now. She had this breast cancer, and I think she took the chemo in Guyana. But when she came here, they said there was no cancer in the breast, but it went to her hips. They saw a mass in her hips. Could that happen?
Yeah, actually it can. With breast cancer, we know that you have a mass in your breast, and we have patients who have the treatment, take the cancer out of the breast, check the lymph nodes, give the, radiation if it's indicated. And, a year down the line, they end up with some aching pain in their hip or their leg, get it checked out, and there's a metastasis to the bone. It absolutely can happen. The thought is, at the time of diagnosis, there are cancer cells that are, kind of lurking around in your body, just waiting for the right opportunity to take home in another part of the body and start to grow. That is why even when we have upfront, when we diagnose a patient and they only have cancer in their breast, we still at times offer patients chemotherapy or other medications, because we do know, even without seeing, something in the liver or in the lungs or on the bones, that there is cancer cells that are likely circulating around. And again, just waiting for that right opportunity to take home in some place other than the breast and start to grow.
Dr.
So
Mace,
that's
we
really
have 3 minutes left. But before we let you go, what type of medication do people have to use, or they have to change their diet, or change their diet with the cancer cells? Sometimes they say you must not eat meat or any red meat or anything. Is that true?
Yeah. So there's been a lot of debate. When it comes to breast cancer, there is no particular one dietary item that has been linked directly to the development of breast cancer. There's been theories about dairy and, meat, all these things. And there really has not been any solid evidence to support, meat causing breast cancer.
Okay.
Having said that, it's certainly important to maintain a healthy diet, a balanced diet, try to, avoid a lot of the processed foods that, we're all are guilty of eating,
I
and
don't like
try to
processed food.
incorporate as much fruit, as much fresh fruits and vegetables. I am not one to say you can't eat meat. Certainly everything with moderation, but no, there hasn't been any specific foods that have had strong evidence to support that it causes or leads to breast cancer.
Dr. Mays, thank you so much for this information. I know my viewers outside will love to hear about this talk about cancer, because a lot of people is afraid of cancer, and a lot of people afraid when they hear anything with their breast, they go, oh, they get worried. I want to thank you. I wish that I could keep you on more long because my time is running out. And I do hope that I could get you back some other time to continue this conversation of breast cancer, because this is very important to the community and to all those persons who need to know about breast cancer, especially those from the Caribbean island, because we always say we're going to use other things instead of we good to go for the medication. So once again, thank you very much, Dr. Mays, for being on Tots and Teens in Focus. I will seek to have you back again on this topic, for cancer is very important to our community.
Well, thank you. And it was my pleasure. And I look forward to the opportunity to come back and speak with you further about this.
Yes, thank you very much. That was
You have a
Dr.
good
Mays
afternoon.
from Brookdale Hospital giving us information about cancer. And I know you people, you community-minded people should have this talk more about your breast, and go see your doctor. Stop using other things. Go see your doctor. Thank you very much.
Absolutely. Thank you.
Oh.